Many times I see you doubting yourself and asking, am I talented enough to get a good rank? It does not matter whether you're talented or not. What matters is how hard you work. Hard work can beat talent. And all of you who are very talented, that's great, but do not stop working hard. The wind of grace is blowing equally for everyone. The one who wins is the one who raises the sail. So yes, raise your sail. What is achieved without effort? Give in your best. This time will not come back again. So we start with a very important topic of the year, and that is otosclerosis. Can you tell me the site of bony labyrinth which remains cartilaginous throughout life? So do you remember the development of the bony labyrinth? Of the membranous labyrinth? Yes? Yes. So what was the inner ear membranous labyrinth developing from? Yes, from the surface ectoderm. And around the surface ectoderm, the mesoderm, around the surface ectoderm became the membranous labyrinth, and from the mesoderm, around it, developed cartilage, and through endochondral ossification from the cartilage became bone. And this bone developed all around the membranous labyrinth to develop what is the bony labyrinth. But certain areas of the bony labyrinth, they failed to ossify. They remained cartilaginous throughout life. And one of this area, very, very important, which we need to know, is the area just anterior to the oval window. So just anterior to the oval window, this area which remains cartilaginous throughout life, it fails to ossify, is what is known as fistula antifenestrum. So what happens if it fails to ossify? It remains cartilaginous throughout life, so it retains its activity to divide. So it goes on dividing whenever there is any external stimuli. It is present since birth, but only when there is some external stimuli, it will start dividing. So when it starts dividing, the bone overgrowth will occur in this area, and sadly, this is the area just anterior to the oval window, which means just anterior to the footplate of stapes. So the footplate of stapes is present here. When the overgrowth of bone occurs, it comes on the footplate of stapes, fixing the footplate of stapes, and this is what we call as otosclerosis. So this here, the footplate fixation of footplate of stapes is what is known as footplate of stapes is what is known as otosclerosis, and the most common site of origin of otosclerosis is fistula antifenestrum. This is the most common site of origin. So what is happening in this area of the footplate of stapes, in the area of the fistula antifenestrum, is that there is a lot of overgrowth of bone occurring. The normal endochondral bone is getting converted into wavy spongy bone. That is why this condition is also known as otospongiosis. And if a cut section is taken and histopathological examination is done of this area, what you will find is a lot of new blood vessels around which there are osteoclasts, there is osteoblast, there is new bone formation, and all this stain blue on H&E, and this is what is known as this blue mantle of Menas. So what is this blue mantle of Menas? This is the H&E finding of otospongiosis, where you see new blood vessels, and around that what you see is new bone formation. New bone formation that stains blue. Does this overgrowth only occur specifically only at the footplate area, or can it go into the inner ear also? Yes, usually it is restricted usually at the level of the oval window, the footplate of stapes area only. But as it can sometimes also go inside into the inner ear, leading to cochlear involvement, when we call it as cochlear otosclerosis. Now, repeatedly has been a question asked in your exam so many number of times. Whenever the question has been asked, the presentation always remains the same. And what's the presentation that is asked? Yes, it is a 30-year-old pregnant female, obviously pregnant, so female, presents with bilateral progressive conductive hearing loss with similar history in mother. So everything possible about otosclerosis has been mentioned in this question. Yes, this site is present. The fistula antifenestrum is present since birth. But what is the precipitating factor for the growth is hormonal changes that occurs in pregnancy. That is why this is aggravated, or this is seen most commonly during pregnancy. So this is seen most commonly in what age? It is seen in the third decade. Most commonly. Pregnancy is an aggravating factor, so it is more common in females with a ratio of male is to female is 1:2. So it is not a gross discrepancy, but yes, it is 1:2 ratio between males and females. Another very important aggravating factor is measles infection. Another aggravating factor is infection with measles. Bilateral progressive conductive hearing loss. So this is bilateral. This is a condition which is bilateral. If I ask you any condition which leads to bilateral hearing loss in children, in fact, what is the most common cause of bilateral conductive hearing loss in children? A child has come to you and the parents are complaining that the child is not hearing for the past few days. You find out there is bilateral conductive hearing loss. What is the most common cause of bilateral conductive hearing loss in children? In children is serous otitis media, whereas in adults the most common cause of bilateral conductive hearing loss is otosclerosis. When will you did I hear nasopharyngeal carcinoma? When will you investigate the patient for nasopharyngeal carcinoma? Unilateral what? Unilateral serous otitis media. So if there is unilateral serous otitis media, you rule out nasopharyngeal carcinoma, unilateral mass in the nasopharynx obstructing the eustachian tube. Whereas any adult with bilateral conductive hearing loss, always what condition you have to think? You have to think of otosclerosis, and it is progressive. What is the hearing loss in serous otitis media? Yes, it fluctuates. Sometimes it goes down. Then fluid again accumulates, so it increases, the hearing loss increases, again it becomes less, again it increases. That is fluctuating. What is this? This is progressive. How much fixation has occurred, that will remain. Later on, when more bone growth occurs, more fixation will occur. So it will progress slowly. It will increase slowly. So it is always progressive. So bilateral progressive conductive hearing loss with similar history in mother. So it is inherited as autosomal dominant. So all these are important points that are asked in your question. So you have to know this, that any adult with bilateral conductive hearing loss, you will have to rule out otosclerosis. Now, whenever usually these females come to the OPD, the moment they have come to the OPD, they start fighting with their husband. Doctor Saab, you please examine my husband first. I think he is deaf. He is not hearing, and he always complains I'm not hearing, and he has got me to get checked. So you first examine him first. Let me be satisfied, and then you can examine me. So then you ask her, why, what happened? Why do you feel that you are hearing good, he is not hearing good? So she will tell you that, see doctor, every evening I take my child to the park. I am sitting with my friends. There is so much of noise there. I can hear properly. I have no problem. I go to buy vegetable, and there also I have no problem in hearing. The moment I enter the house, my husband starts complaining. You are ignoring me. You are not listening to what I am saying. Why is the TV so loud? You are not responding. Yes. So I don't think I have a problem. I think you should examine him first. So what do you think? Is she actually having a problem? Yes. Why? Yes, these patients of otosclerosis, they hear better in noisy surrounding. Why so? Why so? Yes, a noisy surrounding. Noisy surrounding means I don't mean the DJ type of noise. It is that surrounding that you find in the park. The background noise is there, like in the vegetable market. Yes, what happens in noisy surrounding? Have you seen that whenever you're in noisy surrounding, you raise your voice? Yes. So whenever the patient is in the noisy surrounding, the person who is talking to the patient raises his voice, and that raised voice crosses the hearing threshold of the patient. So that is why she starts hearing when the surrounding is noisy. But when we are in noisy surrounding, the people who are talking to us, they are also raising their voice, still we do not hear. Why? Yes, because in our ears, we are also able to appreciate the background noise that masks the raised voice. Whereas in the patient is not able to appreciate the background noise. That because of the hearing loss, that noise is not loud enough to cross the threshold of hearing. But the person who is talking to the patient can hear the noise, and the person who is talking to the patient raises his voice. So that raised voice then crosses the hearing threshold of the patient. That is why this patient hears better in noisy surrounding, and this is what is known as paradoxical hearing better in noisy surrounding, or it is known as paracusis willisii. Paracusis willisii. So this is paradoxical cusis. Paradoxical cusis means hearing. So it is paradoxical hearing better. Hearing better in noisy surrounding. A very, very commonly asked question in your exam. In noisy surrounding. So you are sitting in the OPD here. Here is a young male or a young female who has come to you with a complaint that I feel I'm not hearing. There is history of hearing better in noisy surrounding. Yes, paracusis willisii. And the patient says that I feel I'm not hearing in both the ears, maybe. And you know that any adult with bilateral hearing loss, investigate for otosclerosis. You ask for the history, and yes, they might give you the history that my mother had a similar problem. They might give you the history that yes, when the female might tell you that yes, this problem I had during my pregnancy, during my last pregnancy, and this time again I feel that my hearing loss is aggravated. So all these history you find very, very commonly in the patients, and you know that all this is suggestive of otosclerosis. Any bilateral hearing loss in adult, you know, should be ruled out for otosclerosis. You immediately pick up your otoscope, you have a look at the tympanic membrane of this patient. If this is also otosclerosis, what do you think will be the appearance of the tympanic membrane? Will it be pearly white, red, blue, pink, flamingo pink? What do you think? Did I hear flamingo pink? It will be pearly white. Then where is flamingo pink seen? What is flamingo pink? Yes, the pink flamingo is a pink bird. Yes. So where is flamingo pink seen? That is also seen in otosclerosis. But why in otosclerosis should the tympanic membrane appear pink? Yes, whenever the otosclerosis is active, which means that active division is taking place on the promontory area, on the medial wall area. There is increased vascularity, and this increased vascularity through the intact tympanic membrane makes the tympanic membrane get a pinkish hue, a pinkish appearance. That is what is known as flamingo pink tympanic membrane. So flamingo pink tympanic membrane is also known as Schwartz's sign. Schwartz surgery is done for. Schwartz surgery is, you remember, cortical mastectomy, also known as simple mastectomy. You're just simply opening the mastoid hair cells. Cortical, just opening the cortex to remove pus from the mastoid. That was done for mastoiditis. Yes. So this is Schwartz sign of flamingo pink appearance. This is seen only in active otosclerosis. Just see here. Can you see the pinkish on the medial wall? The tympanic membrane is appearing good. Usually you see it in the posterior part. That is the area of the oval window. But yes, this was a report where bilateral pinkish appearance was seen. This is, you are seeing mainly in this area. But what you need to know is that, yes, if it is flamingo pink appearance that you are seeing, this is the pink flamingo bird. So if you are seeing the flamingo pink appearance, then that is indicating that this is active otosclerosis. Active otosclerosis. You see the flamingo pink appearance. So then why did I say that in otosclerosis, the tympanic membrane that you will find will be pearly white? Because active cases are only 10%. Only 10%, which means 90% of patients, the tympanic membrane will appear normal, pearly white. Pearly white. Yes, this increased activity because of increased vascularity will be seen only in 10%. What happens later on? It becomes mature. After some time, only whenever there is precipitating factors, then the activity will occur. After some time, the growth will stop and the bone will become mature. The vascularity will go down to normal. So then it will have the normal pearly white appearance, and that is 90% of the cases. So you have a look at the tympanic membrane and you see the pearly white tympanic membrane, or maybe you see the flamingo pink appearance, and your suspicion the increases that this can be otosclerosis. So immediately what you do in the next is, yes, you take out your tuning fork. So you take your tuning fork. Quickly tell me, yes, Renis, if it is otosclerosis, let me see, it is usually bilateral, but let us for testing purposes, let me say it is right ear. Okay, right ear otosclerosis. Tell me, Renis will be positive or negative? Negative? Positive? Okay, Renis will be negative. Renis is negative in which two conditions? Conductive or severe sensorineural hearing loss. Here it will be negative. Weber's will be towards the worst ear. Worst ear. Even if it is bilateral. Weber's is a very sensitive test. It can pick up even a 5 decibel difference in both the ears. So it will get lateralized towards the worst ear. Towards the worst ear. ABC. Absolute bone conduction. This is a test for sensorineural hearing loss. You will not do it here. By chance you do it here, it will be, tell me what will be ABC. Bone conduction here will be normal. It will be same as examiner. Same as examiner. Shawback. Shawback will be lengthened. Shawback is same like ABC for sensorineural hearing loss. For sensorineural hearing loss, bone conduction, that is ABC as well as Shawback, is shortened. Whereas in conductive hearing loss, Shawback will be lengthened. It will be lengthened. Gellies, what is Gellies? What is Gellies? Gellies is you increase and decrease the pressure of external auditory canal. If the tympanic membrane is intact and the ossicular chain is normal, then on increasing and decreasing, there is mobility of the tympanic membrane that will lead to ossicular chain restriction, mobility restriction, then coming back to normal. Restriction coming back to normal. So patient will report there is a change in hearing when you increase and decrease the pressure of external auditory canal. Whereas if the ossicular chain is already fixed, whether you increase the pressure, whether you decrease the pressure, there will be no change in hearing. So that is Gellies. Gellies here, when there is change in hearing, we call it as Gellies positive. Here Gellies will be negative. Gellies will be negative. So you do the tuning fork test and you find that it is a conductive hearing loss. Will you like to confirm by the audiogram? Yes, audiogram will confirm it. Will there be AB gap? Yes, AB gap will be present. So this is how we will approach. Yes, where patient has come to you with a complaint of decreased hearing. Okay, patient is sitting in front of you. Patient has complaint of decreased hearing. The moment you hear only hearing loss, you ask him any other complaint, any discharge, any pain, nothing. Yes, so if there is any discharge, if there is any pain, then you know that you can think of either external ear or middle ear. Now there is nothing, no pain, no discharge, only hearing loss. So you have to think of complete ear. It can be external ear, it can be middle ear, it can be inner ear. Yes or no? Yes. External ear, up till tympanic membrane, you can easily see and you can find out. So immediately you will not jump on doing all these tests. You will have a look at the external auditory canal. You see the external auditory canal and what you see is pinna is normal, external auditory canal is normal, up till tympanic membrane normal. So now you knew that the patient has hearing loss. It could be external ear, middle ear, inner ear. Now when you examined, you ruled out external ear is good. Now your DD is middle ear, inner ear. Yes. So then is when you started doing the test. You did the tuning fork test. Tuning fork showed you it is negative. Negative means you have again ruled out what? Inner ear. Inner ear gone. Now you have made the diagnosis. It is a defect in the middle ear. You confirm it by audiogram. Audiogram also shows, yes, conductive hearing loss. It also tells you exactly how much is the hearing loss. So when the audiogram also shows AB gap is present, there is conductive hearing loss. Now you are fixed that yes, this is middle ear. So what is the test that you will do to find out, to confirm that what disease of the middle ear it is? When the tympanic membrane is intact, how will you know the condition of the middle ear, whether it is ossicular fixity, ossicular dissociation, or there is fluid in the middle ear? With intact tympanic membrane and no much changes of the tympanic membrane, you can think of all these three things. How will you confirm out of these three which it is? Yes, that is by impedance audiometry, tympanometry. Before that, yes, tell me, will there be any changes more than AB gap in the audiogram, in the pure tone audiogram? Yes, very, very important. You will see a dip at 2000 hertz. At 2000 hertz, very important. Listen to this very carefully. You will see a dip at 2000 hertz. Whenever you see audiogram and you want to diagnose it is otosclerosis or not, don't just start looking for the dip that, okay, only when I see the dip, this will be otosclerosis. No, the first thing is look for whether it is a conductive hearing loss or not, which means look for AB gap. Only then you know it is conductive hearing loss. Then you see whether this is otosclerosis or not. Cahardt's notch might be present, might not be present. It might not be present in all patients. But if it is present, then yes, you know it is otosclerosis. But still, it is not that you will look for the Cahardt's notch and there is no AB gap. Still you tell it is dip at 2000 hertz is Cahardt's notch. No. The first thing is it has to be conductive hearing loss. There is a AB gap. Yes, there is AB gap. Bone conduction is normal. Bone conduction indicates sensorineural pathway. Air conduction indicates conductive plus sensorineural pathway. Sensorineural pathway is good. What is the defect? Conductive pathway. That is why we say AB gap means that there is a gap between bone conduction, air conduction. Bone conduction is good. So it is what hearing loss? Conductive hearing loss. So it is conductive hearing loss you have seen. And now you see the bone conduction curve. The dip at 2000 hertz is in only the bone conduction curve. Cahardt's notch is seen only in bone conduction. Bone conduction curve at 2000 hertz. Yes. So why in bone conduction curve there is a dip in otosclerosis? Yes. And that too is 2000 hertz. Okay, just see here. We have this here is the membranous labyrinth. Okay. And this here is the bony labyrinth. This is the bony labyrinth. In the bony labyrinth, we have the foot plate here, on which is present on the oval window. So we have the oval window on which is present the footplate of stapes. Now what is the mechanism of bone conduction? In bone conduction the skull vibrates. So when the skull vibrates, the vibration go from the bone to the membranous labyrinth to the organ of Corti to stimulate it. Yes. Now when there is fixation of footplate, when this is completely fixed, okay, this is fixed. Now what will happen? In this area, from this area of the bony labyrinth, the footplate develops from the bony labyrinth. Yes or no? We know that. Yes, the footplate also develops from the bony labyrinth. So now this area is not vibrating. This is not vibrating. So in this area, there is, whenever there is bone conduction, this part of the bone conduction will be missing. What is this part? The frequency of the footplate is 2000 hertz. So at 2000 hertz, you will specifically see a dip in the bone conduction curve. And just see, that is not too much of hearing loss. In fact, it is more than 25 decibel. We call it as hearing loss, no? More than 25 decibel. After 25 decibel, we say it is normal. So it is still within normal, which means that this part which is coming through the footplate area of the bone conduction, that is very minute. So it is not causing so much of hearing loss. But yes, this is a very important finding. Why this is an important finding? First, this is occurring in the bone conduction curve. Why it is occurring in the bone conduction curve, you already know. Second, when you will treat this patient, when you will mobilize the footplate of stapes area, now what will happen? Will this curve become normal? Will this dip disappear? Yes or no? Yes, it will. Usually, whenever there is a dip in the bone conduction, that indicates that the nerve, bone conduction is nerve, sensorineural pathway, is damaged. and that is usually not reversible. But this is one dip which is reversible. So this is a reversible dip. Reversible after surgery. After surgery. So you see the Carhart's notch is present here, yes, and now your suspicion is very, very high that this is otosclerosis. You just need to document it by confirming by tympanometry. So when you do the impedance audiometry has two parts, tympanometry and stapedial reflex. What will be the tympanometry finding? Yes, what will be the tympanometry finding? Yes, the compliance will go down. Middle ear pressure will be normal. Middle ear pressure is altered because of eustachian tube. Eustachian tube is normal here. Only the compliance has gone down because of ossicular fixity. Only the mobility of the tympanic membrane has gone down. What is this type of curve known as? Yes, this is the AS type of curve. And also, what will be the stapedial reflex? Stapedial reflex will be absent. Stapedial reflex, why? Because stapedial reflex, what you do for stapedial reflex, you give a 70 decibel or maybe a 90 decibel sound to the ear. So if I'm testing in the right ear, I give a 90 decibel sound or a 70 decibel sound. So there is a hearing loss. There is ossicular fixity. Can you tell me footplate fixation? If it is complete, it leads to how much hearing loss? Complete fixation of footplate of stapes leads to maximum 60 decibel hearing loss. If it is not complete also, it can lead to 40 decibel, maybe it is 50 decibel. Yes. So suppose if consider that there is only 40 decibel hearing loss. I am giving a 70 decibel sound. By the time it reaches the inner ear, it is left how much? 70 minus 40. Only 30 decibel. So will a 30 decibel sound in the inner ear, in the auditory pathway, be loud enough to elicit a stapedial reflex? No. For eliciting stapedial reflex, you need at least 70 decibel sound. Same if you give a 90 decibel also. Then also, will you get stapedial reflex? No. 40 decibel will be lost. It will only remain as 50 decibel. So which means that the tympanometry will confirm that yes, this is otosclerosis. So which means if I tell you that so many tests, we do not have the time. Do only one test, tell me the diagnosis. You are suspecting otosclerosis, do one test and tell me the diagnosis. Which test will that be? Tympanometry. Tympanometry will show the AS type of curve. Stapedial reflex will be absent. It will be absent and that will confirm that this is otosclerosis. And what about CT? Will you go for a CT scan? Any CT for and looking for anything of the ear has to be with CT. HRCT. Will you go for HRCT here? Usually it is not required. By chance you are in a doubt whether it is otosclerosis or not, then you can go for HRCT. Definitely it will show the thickening of the foot plate, that yes, it is more thick than what it is usual. There definitely you will be able to see that area of overgrowth, the immature bone as hypodense. But because HRCT is more expensive and simple test like tympanometry, it is just a minute test. Patient's cooperation is not required. It is very, very less expensive. That will tell you the diagnosis. Then you do not need to go for HRCT. Otherwise, if HRCT is also in the choice, then and best is asked, then best definitely will be HRCT because that is documenting where exactly, how much thickness, which all area involved, and when you are suspecting a cochlear involvement. In any patient of otosclerosis, if along with conductive hearing loss, you're finding a sensorineural hearing loss also, which means you're getting a mixed hearing loss, and you are in a doubt that this is otosclerosis, but mixed hearing loss, sensorineural involvement also. So then to see, you always get HRCT done, and there what you will see here, just see this, I will just orient you. This is the area of the mastoid. This is the area of the petrous. We know that the ear is like a tunnel in the temporal bone. So here we have the external ear. The middle ear is this. We have the inner ear here. This is the inner ear. So in the inner ear, what you're seeing is that there is area of loose hypodense area. Can you see this? All around the cochlea, all around the cochlear rings, there is hypodense area. This is what is known as a double ring sign. A double ring sign of otosclerosis. That is a hypodense area all around the cochlea. So To confirm then, if you're suspecting cochlear otosclerosis, you can go for HRCT. Otherwise, tympanometry will suffice. And yes, has been asked in your exam, what is the tympanometry finding of osteogenesis imperfecta? Why this condition? Why am I even telling it here? Osteogenesis imperfecta? Yes, because of its association with otosclerosis. This is a condition where there is otosclerosis with blue sclera and osteogenesis imperfecta. This is what is known as Van der Hoef syndrome. Van der Hoef syndrome. So because of its association with otosclerosis, it can be present with otosclerosis. In your exam has been asked, what is the tympanogram in osteogenesis imperfecta? So what is the audiogram in tympanogram in osteogenesis imperfecta? If they are asking you, what they are asking you is otosclerosis. So what curve? Yes, AS type of curve. So in this patient who came to you with bilateral hearing loss, okay, so patient adult male or adult female came to you with a complaint of bilateral hearing loss, and you know any bilateral hearing loss in adult, maybe otosclerosis. So immediately to rule out, you see external aortic canal, everything is appearing good. So you know that it can be middle ear, inner ear. You confirm it is conductive hearing loss, localized that it is middle ear. Now you exactly to know what condition of the middle ear it is, you go for tympanometry, and tympanometry showed you the AS type of curve. We have confirmed this is a patient of otosclerosis. How will you manage this patient? What will you do? You know the pathology, so you know the management. What is the pathology? Fixation of foot plate. What will you do? Mobilize it. How will you mobilize? So here is the foot plate. This has got fixed. This has got completely fixed. So what you will do here now is you will remove this foot plate. So how will you remove the stapes? We will cut this stapedius tendon so that now the stapes is free. We will dislocate this included stapedial joint. We will remove this complete stapes. Yes, this used to be known as stapedectomy. It is not done now. Nowadays, it is not done. Why? Because when you are removing the complete stapes along with complete foot plate, you are leaving this oval window exposed. So now there are increased chances of fistula formation. If the fistula forms, there are increased chances of inner ear getting damaged. There are increased chances of sensorineural hearing loss. So now what is done is, instead of removing the complete stapes along with the foot plate, only what is removed is suprastructure. What is suprastructure? This area. You cut the stapedius tendon. Definitely you have to cut it to free the stapes. You dislocate the included stapedial joint. You remove the head, the neck, anterior and the posterior crura. So you remove this part, and this foot plate which was fixed, you leave it behind. And after leaving foot plate behind, what you do is you make an opening in the fixed foot plate in the center. And on this opening, you place a piston, the other end of which is attached to the long process of incus. So now when the incus will move, this piston will move, and that will transmit the vibration into the inner ear. So this is what is known as stapedotomy. So earlier what used to be done was dectomy. Now what is done is stapedotomy. Is it a unilateral or bilateral condition? Otosclerosis? It's a bilateral condition. So you will do stapedotomy in one ear or in both the ears. 1 year first. Which year first? Choose, you are the surgeon. Which year first? Better year or worst year first? Worst year first? So that you can have practice in the worst year, then you can go for the better year. It is always the worst year first. Yes. Why worst year first? Yes, because you are dealing with a very sensitive area. What is the area that you're dealing with? The footplate of stapes. If there is any complication, what can be the complication? There can be fistula formation. There can be sensorial hearing loss. So always, if it is gone following surgery, what will go the worst ear? Better ear will still be left behind. So it will be stepidotomy in the worst ear first. The worst ear first. So here is a patient and who has been posted for stepidotomy. So you are the intern posted in the OT, and here is a patient who has been posted for stepidotomy, and you are taking his consent. That is what interns are made to do. So you are taking his consent, and yes, in the consent form always is written, I have explained the complications. So okay, you tell him that, see, what is going to happen is we are going to operate on your ear, and following surgery there can be fistula formation, and following that maybe what you are hearing now, that also you will not hear. So see, I have told you everything. Now you sign that you are ready for surgery. So the patient will tell, doctor, thank you. I do not want to get the surgery done. Yes, thank you so much that you have told me this. Nobody told me all this. So, but see, I cannot hear and I am very disturbed because I cannot hear. It is very debilitating for me. Please tell me what I can do. You are only my God. Now you only tell me what I can do. So what is the alternative of the surgery? Yes, alternative. You have to give him some alternative. So yes, then these patients, you can go for hearing aid. Many of the patients, if you tell them the complications, they will back out. So in these patients, what is the alternative for surgery? Yes, the alternative for surgery is hearing aid. Alternative is hearing aid. Alternative for surgery is hearing aid. Now, if you are telling this to the patient and you are telling any patient that, see, you have to go for hearing aid. Surgery, there can be so many complications, go for hearing aid. The patient is telling you, see, doctor, I have come to the government hospital. Here, the hearing aid is not free. Surgery is free. So don't worry, whatever will happen, I have left to God. You do my surgery. When will you tell the patient, no surgery in your ear at all? You have to go for hearing aid only. So what is the important contraindication of surgery? Where you will ask the patient only for hearing aid. Yes, when the patient has only one hearing ear. I told you this is a bilateral condition. So if because of the condition or because of any other condition, patient's one ear is gone, patient has only 1 year left, then you never operate in that ear because of the increased chances of complication. So the important contraindication for surgery is only one hearing ear. But this is bilateral condition, no? So do we operate only 1 year? Yes, I told you that we have to operate the worst ear first. What does that mean? Worst ear first means the other ear also, do we operate or not? Yes, worst ear first means you operate the worst ear first and then you wait for at least 1 year to see whether there is any complication or not. If there is no complication following surgery for 1 year, then you can go for surgery on the better ear. So it is worst ear first. Now also, can this be an active otosclerosis? Can you come to know whether it is active or not? Because we know that if it is active in acute conditions, we never operate. In acute conditions, we always give medical management till the acute condition has been resolved. So, can we come to know whether this otosclerosis is active right now or not? Yes or no? Think and tell me. Any sign of activity? Do you know? Yes, it is Schwartz sign, flamingo pink appearance. So if there's flamingo pink appearance of the tympanic membrane, we know it is active otosclerosis. In that case, you will not operate. You will not operate, you will give medical management. So for active otosclerosis, you give medical management with sodium fluoride. Sodium fluoride. What sodium fluoride will do it? It will accelerate the maturation of the focus. What it will do is it will stop all destruction. Stop all destruction means it will stop all destruction. Stop all destruction means it will decrease the proteolytic enzymes It will decrease. It will decrease the osteoclastic activity. It will increase the maturation of the focus. It will increase the bone formation. Bone formation and maturation. So once the bone has matured, then you can take up the patient for stepidotomy. So for active cases, you go for sodium fluoride. For mature cases, you go for stepidotomy. Which year first? Yes, worst year first. Not willing for surgery, patient not willing for surgery, you can go for hearing aid. So what are the contraindications for surgery? Contraindication, important contraindication is only hearing ear. If it is active otosclerosis, then in active, we will wait, we will give sodium fluoride and we will wait. So we will wait. It is not a absolute contraindication for surgery. We are going to wait. Also, tell me one condition which aggravates this condition. Some hormonal changes. Which one? Yes, pregnancy. So pregnancy can aggravate it. So if there is a pregnant female who is having this right now, will you operate during pregnancy? No, this is not life-threatening. Why operate during pregnancy? So wait for the pregnancy to be over. So again, in pregnancy, if it is, the patient is pregnant right now, then wait. Do not operate during pregnancy. You will wait. Yes. Now another place where we have to be cautious while doing stepidotomy. We know that, see, what we are doing is we have replaced the stapes with the help of a piston. Yes, this piston can be made of a Teflon, or it can be made of steel, it can be made of titanium. So this, now when it moves, this is placed over the opening that we have made on the oval window, which means that the movement will be a little more. The stapedius tendon also we have cut. The stapedius tendon also has been cut, which means stapedius tendon, it sits on the, it is holding the neck of the stapes. Yes, so it restricts a little movement, normal movement also. That is also not there here. So now it will move a little more. So in patients in whom there is Meniere's, what is Meniere's? The endolymphatic sac is dilated. Yes, dilated. So here we have the utricle and saccule. So here this has become dilated and it has come very near to the foot plate now. So now when the foot plate is not there, what is there is the piston over it. So when the piston will move, if it is very close, because of dilatation, the utricle and saccule have come very close. So this can stimulate it, leading to vertigo. So that is why in Meniere's, we have to be very cautious while doing it. While doing this surgery, you have to be very cautious. So in Meniere's, there is a caution. And also in any profession, there is sudden pressure changes. Now the foot plate, on the foot plate, we have just a piston. That is also not attached to the stapedius. So now if there are sudden pressure changes, what will happen? This piston can be pushed into the inner ear. So when we know that we have put the piston, is there any profession know whether there can be sudden pressure changes? Yes, in pilots or in divers. Yes, especially in pilots, which is very, very common. So in pilots, stapedectomy is never done. Stapedectomy is a contraindication, but anyway, nowadays what we are doing is stepidotomy. So then these pilots in whom stepidotomy is done, they need to be grounded for a few weeks to few months. So there again we have to be cautious. So in pilots, you have to be cautious. So now we know that whenever we are looking at a patient whom we are suspecting otosclerosis, how we confirm it and how we are going to manage this patient. The management will depend upon whether it is active, whether it is mature, also on the profession of the patient, also on if the patient right now is pregnant or not, whether it is only 1 year that is left now, the patient's other year is completely dead. So there are so many things that you will look before operating. It is not only that yes, you have confirmed by tympanometry that this is otosclerosis, now you can just take up the patient for operating, doing a stepidotomy. There are many things that you will have to look before you operate in a patient of otosclerosis. So now you have operated, okay, you have done the surgery. Now post-operatively, will the Cahard's notch disappear? Yes or no? Yes, it will disappear. Okay, now tell me what will be the tympanogram finding. Earlier the tympanogram finding was the AS. Now what will happen after surgery? Yes, after surgery what I told you is that we cut the stapedius tendon. So now when the stapedius tendon is cut, the ossicular chain becomes very freely mobile. Yes, excessively mobile. That is what you will pick up on tympanometry. So you will now get a AD type of curve. AD type of curve post-operatively. And also post-operatively, just see, this is what can happen post-operatively. What have you done in the surgery? The footplate was fixed. The cause was repeated division at fistula antifenestrum. That we couldn't have done anything. That is occurring because of unknown causes. We cannot do anything about that. What has happened is now the footplate has got fixed. So what we have done is we have remedied that we have mobilized the footplate of stapes. So can it not get fixed again? Yes. Can the overgrowth of bone not occur again? It can occur. So post-operatively, again that can occur, again refixation can occur, and that can lead to hearing loss. So post-operatively, again there can be hearing loss, and the conductive hearing loss can be either because of refixation. But do you think that refixation can happen immediately following surgery? No, it will happen years together. Again, it will take many years to reach to that level of fixation where the patient will again experience hearing loss. What if following surgery, patient immediately notices that I felt that there was improvement, but suddenly I feel that again I am not hearing? Then what can be the cause? Yes, this piston that you have put, maybe it has got dislodged because we made a small opening on the footplate on which we have fixed it. So by chance, from that small opening, it has got dislodged. Yes, so now it will not put pressure on the area which is not fixed. So the vibrations will not be able to go into the inner ear. So what can happen following surgery is it can get dislocated piston. Also what we do here is we saw how the piston looked like. Yes, this area, this is attached, this is on the incus. This area is crimped around the incus. And the other end is put on the stapes footplate, on the opening that we have made. Now, if we crimp it very hard, so what can happen is already the area of the incus long process, this area, the blood supply is already weak. Now, what you have done is you have crimped these piston very, very tightly. So now you have decreased the blood supply, and that can lead to ischemia in this area, and this can lead to, again, the ossicular chain will not be in continuity. Again, this area will get necrosed. So there can be necrosis of the long process. Necrosis of long process. Long process of incus. And if the patient has come to you following surgery and he's telling you that I felt that I was hearing good following surgery, but now suddenly I feel that the hearing is no more, hearing is not there again. And when you get the audiogram done, you see that there is a mixed hearing loss. There is not only a conductive but also sensorial hearing loss. Yes. And patient is also giving the history that there is sudden onset, there is vertigo also. Then you will rule out a fistula. So if there is a sensorineural hearing loss or a mixed hearing loss following surgery, then it can be because of a fistula. Now there can be some other complications following surgery, post-operative. There can be certain complications following surgery. These are not the very, very common complications following stepidotomy, but yes, they can occur. See, where we are operating, where we are making the opening, this is the footplate of stapes area. Just above the stapes, we know on the medial wall, just above the stapes goes the facial nerve. Yes, so this facial nerve can be dehiscent. I have told you earlier that the fallopian canal can be missing in some area, and that area very, very commonly is above the footplate of stapes. So if we have put the piston here and by chance in this patient the fallopian canal is dehiscent, then it will continuously compress the facial nerve and there can be facial nerve palsy. Following surgery, there can be facial nerve palsy. So what do? Nothing needs to be done. Just open again and open up the patient again and either change the position of the piston or you can remove the piston. So facial nerve palsy can occur. And yes, do you remember what fenestration operation was? Here is the footplate. Initially, earlier, when stepidotomy was not known, that this surgery was not invented, the surgeon saw that the footplate is fixed. So they thought that sound is not going because of footplate fixation. Anyway, no problem. We are seeing a bulge here. Let us make an opening here through which the sound will go inside. Yes, so what was this? This was known as fenestration operation. This was known as fenestration operation. Why? Because a fenestra was made. On which semicircular canal? Which semicircular canal is this? On lateral semicircular canal. So what has the surgeon ended up doing? They have made a fistula on the lateral semicircular canal. Any external pressure changes will go into the inner ear and lead to vertigo. So that is why it is no more done now. This was what tympanoplasty? Type 5 tympanoplasty. Yes, this was type 5 tympanoplasty. It is no more done now. Not done. It is no more done now. So, okay, you are quickly going to keep your pens down. Yes, keep your pens down. Sit straight. Yes, okay. Tell me, you are sitting in the OPD. Here is the patient who has come to you. What is his complaint that will make you think that this is a patient of otosclerosis? Tell me, what complaint? Bilateral hearing loss. Yes, will the patient give any history of hearing better in noisy surrounding? Yes, what is that known as? Paracusis velesi, paradoxical hearing better in noisy surrounding. Okay, if this is otosclerosis, what will be the appearance of his tympanic membrane? Pearly white, flamingo pink, bluish, red. Yes, pearly white. Flamingo pink is seen in which condition? Pinkish tympanic membrane is seen in which condition? Was a question. Flamingo pink is seen in which condition? Again was a question. What is the answer? Otosclerosis. It is seen in otosclerosis, but that is seen in which otosclerosis? Active otosclerosis. 90% cases, the tympanic membrane appearance will be pearly white or flamingo pink. It will be pearly white. Flamingo pink will be seen only in 10% of the cases. Tell me one test with which you will confirm that this is otosclerosis. Yes? Tympanometry. What will be the finding in audiogram? Don't tell me only Cahardt's notch. First tell me AB gap. There will be AB gap. Yes, AB gap, that you have to see when you have to diagnose. That will tell you it is conductive hearing loss. Along with plus there will be Cahardt's notch. Cahardt's notch is dip at 2000 Hertz. In air conduction, bone conduction. Only in bone conduction. Dip at 4000 is seen in 4000 is acoustic dip. That is seen in noise trauma. This is at 2000 Hertz. What is the tympanogram of osteogenesis imperfecta? Tympanogram is a S type. Why AS type? Yes, because that is seen associated with otosclerosis. What is that syndrome known as? Van der Hoef syndrome. What is Van der Hoef syndrome? Osteogenesis imperfecta, blue sclera and otosclerosis. When will you not go for surgery as the management in a patient of otosclerosis? Yes, very good. Active otosclerosis, you will wait. What's the important contraindication for surgery? Only hearing ear. Alternative for surgery? Hearing aid. You will do stepidectomy or dotomy? Stepidotomy in which year first? Worst year first. Not willing for surgery? Hearing aid. What is the important complication following surgery which can lead to mixed hearing loss? fistula. Following surgery, immediately the patient has again hearing loss, conductive hearing loss. Now, what has happened? Dislodgement. Yes. After some time, maybe hearing loss, then maybe necrosis. After a long time hearing loss, then that is maybe refixation. Following surgery, immediately fistula, or following pressure changes, fistula. That will lead to what? Hearing loss. How will you come to know? Yes, that is by mixed hearing loss. Along with that, because of fistula, there will be vertigo. So what is the processes that you use following surgery in stapes fixation? In otosclerosis? Yes, that is known as stapes piston. So that is what you need to know in otosclerosis, and let us quickly see the video of stapedotomy. Before we see the video of ear surgeries, a note of caution for all my students. Please don't expect that whatever you are seeing, you are going to see. The moment you see, it will be absolutely crystal clear to you, like how it became clear to you when we read about it. The surgeries of the ear are not simple to understand, not only for you, but even for the PGs. It is not until they have assisted so many surgeries and they have reached up till the second year after assisting so many surgeries that they can actually make out what is being done. So definitely, if you see it for the first time, don't expect that it is going to be absolutely now perfectly clear and you will understand in the first time that this is whatever you are seeing. But I have tried my best to give you a glimpse, just a glimpse of what the surgeries of the ear mean. You have already understood it very beautifully when we have done the theory part, when we have understood the concepts part. This is just to give you a glimpse of what exactly we are doing in the surgeries. How much you are understanding is sufficient. I have tried my best to give you a very magnified view so that the steps that you need to know, at least they are visible, and how much you are understanding after seeing this is perfectly okay. So let us quickly see how stapedotomy is done. This is being done in the left ear. So this is the left ear of the patient. Let me just orient you first. So this is the superior end and that is the inferior end. Here you can see the lateral process of the malleus, the handle of the malleus, that is anterior and this is posterior. On the anterior side, you can see in the anteroinferior quadrant, you can see the cone of light there. Right. So now what we will be doing here is we will be giving an incision just lateral to the tympanic membrane in the skin of the external auditory canal. We will raise the external auditory canal skin until we reach the annulus. And once we have reached the annulus, we will also raise the whole of the tympanic membrane along with the skin of the external auditory canal. So this complete flap, the external auditory canal skin along with the tympanic membrane will be raised. This is what is known as tympanomeatal flap. And then we will be able to have a look at the middle ear. Now, if I am going to raise the flap from here, this is which part of the tympanic membrane? This is the posterior part. So what structures I will be seeing in the middle ear will be the structures that are present in the posterior part of the middle ear. And what are these structures? You already know. Yes, we will be seeing the oval window on which we will find the stapes, and we will be also seeing the round window below the oval window. So now let us see how the surgery is done. So we have placed a cotton there. We are doing this under local anesthesia. Incision is given, as you are seeing here, in the external auditory canal skin lateral to the tympanic membrane. This incision is what is known as transcanal or the Rosen's incision. We have not approached postorally here. Yes, we have just given the incision in the external auditory canal skin. We have raised the external auditory canal skin up till the annulus, and from there also the tympanic membrane we are raising and we are placing it forward. So these structures that you are seeing here are the structures in the middle ear in the posterior part. So let me orient this to you first, what you are seeing. So what we are seeing here is the posterior part of the middle ear cavity, and in the posterior part, this structure is the long process of the incus, which is articulating with the stapes head. And below that, on the neck of the stapes, you can see something which is coming from the posterior wall. So from the posterior wall, from this pyramid-like structure, what is this? Yes, this is pyramid from which is coming some structure attaching to the neck of stapes. So what is the structure here? Yes, this is the muscle that attaches to the neck of stapes, and that is stapedius. So we can see this window here, that is the oval window. This here is the promontory area. And below there, this opening that you are seeing is the round window. So what we are going to do now is we are first going to section, we are going to cut the stapedius tendon, then we are going to disarticulate the incrudostapedial joint and then remove the suprastructure of stapes, and then we will make an opening in the footplate of the stapes which is fixed in this patient, on which we will place the prosthesis, the Teflon piston. So let us see. So we are now cutting the stapedius tendon so that the stapes is free and we will be able to remove the suprastructure properly. The incrudostapedial joint is now being disarticulated, and yes, we can see that the suprastructure of stapes is now removed. The suprastructure of the stapes is the head, the neck, anterior and the posterior crura. The footplate which is fixed is left behind. On the footplate, an opening is made either with the help of a very fine drill, or it can be done with the help of a laser. So once the opening is made, now the Teflon piston is being placed, and this will replace the stapes. One end is being placed on the opening that we have made on the fixed footplate, the stepidotomy, and the other end is crimped around the long process of incus. We are placing a gel foam there to absorb whatever blood, and now we will reposition the tympanomeatal flap back. So now you are seeing that the tympanomeatal flap is being repositioned back. So these are the steps of stepidotomy, and this is how stepidotomy is done.